Good afternoon, everyone. This is Chapter 4, Today's Healthcare Environment. There have been some major changes since 1965 with the addition of Medicare and Medicaid. The reason for it is because the life expectancy has grown with the advantages that have come along with healthcare. There have been so many discoveries health-wise that people are living to be older. So Medicare and Medicaid was born. It's all about preventative care. Patient education is stressed highly. If not funded, the various organizations will put out what they want to be taken seriously by the people who use it. But there is some government legislation that involves who gets Medicare and who can have Medicaid. There is such a thing as fixed monthly payments, which is medical care for a fixed monthly fee. Happens all the time with Medicare, which is free, but for an additional coverage, that is a monthly Part D that has to be paid for. There's also third-party payers. Now, what kind of care is available? Well, there's managed care, MCO. They are kind of the gatekeeper of care. There is an HMO, a health maintenance organization. I think everyone is kind of familiar with that. And they are providing a wide range of services for a predetermined set of fees that have been designed by a limited group of providers. And if you pay for an HMO to care for you and your family, let's say, you must choose their providers. You cannot have anyone in the PPO, which is a preferred provider organization. For example, I use the doctors at Stanford, so that is a PPO that I am involved with, Blue Cross and Blue Shield. The patient has to use a provider who's under contract with the insurer for an agreed-upon fee. So I go to whatever doctors at Stanford, they take my Blue Cross and Blue Shield, which is great. If they charge more for a particular whatever that I'm having done at the time, they submit it to Blue Cross and Blue Shield. Blue Cross and Blue Shield will pay what has been agreed upon, and the rest gets written off. I kind of like being able to choose my own provider. Funny that way. There's another plan where you can have an EPO, exclusive provider organization, and it has the concept, the best of the best, the concept of both the HMO and the PPO. Now, let's talk about the federal assistance programs, Medicare. This is for people who are 65 and older. I don't like where it says health care for the elderly because I'm getting there. But health care for people over 65 and beyond, or anyone who might be seriously disabled at any age, or anyone who could have end-stage renal disease or any other debilitating ailment at any age. Someone could be 15 years old and have severe cerebral palsy, let's say. They would be able to apply for Medicare. Serious debilitating ailment. And it is regardless of wealth or income. Everyone can have it. Medicare is free. The additional parts of it are not. Medicare, however, rations health care. In other words, it's for the hospital after so many days and what happens within a hospital. But people go to the doctors and people have prescriptions, and that's an additional part that you can purchase reasonably for monthly coverage. Now, what is Medicaid? The difference between the two. Medicaid is a federal state-by-state program. Every individual state will implement their own Medicaid. They provide financial assistance to anyone that is poor and indigent, meaning they have no means of providing the funds to take care of them. They may be able to afford to eat and put a roof on their head, but nothing else, so they're considered indigent, but they cannot afford the cost of medical care. So rationing takes place there too. Only such things can be done and not overdone. And again, while I don't necessarily think that this is the right way to go, it's America, and so people can do as they wish. Not all providers accept Medicaid. They all accept Medicare, but not all accept Medicaid. Now, what are DRGs? You have to be familiar with this. Diagnosis-related group. I can remember when this came on board, and it came on board over 3 successive years. It's basically, there were people back in the day that would go into the hospital, wealthy people, let's say, once a year, without any particular diagnosis. They'd go in for, just give me like an oil change. Go, just check my heart, check my blood, do everything you have to do, and let me know how I am. And they'd get covered in the hospital. Well, insurance companies and hospitals were losing a ton of money, and they didn't have the beds available for people who really were sick. So they instituted, and it's primarily for the insurance companies, really. They instituted these DRGs, and they took every known illness, classified it into 467 categories. And it will take, really, it says Medicare patients by illness. It takes every person and gives them a code. Like high blood pressure has a code, but if it's high blood pressure brought on by congestive heart failure, because of the excess fluid, then it's given a modifier. So there's ways to do it. The treatment have a sum that is preset for treatment of every category, regardless of how many bed days used. So you wonder, why do you have heart surgery and come out in 5 days? Well, there you go. They want you in. Of course, they'll tell you it's because being home is better, et cetera, et cetera. And it probably is, but some people need more care than not. The only way anyone can get around it, there's got to be a back door. And the only way is that on every insurance form, if you look at it, there are 4 areas that a diagnosis can be put in. So if someone's going in for, let's say, a back ailment like I did, you can't all of a sudden say, well, I'm going to treat them for anemia, and by the way, they have high blood pressure. Let me check and see if they have all those migraines. Not going to fly. Everything with the back can be taken care of, and things that are related to it, MRIs, injections if necessary for pain management, any of those things could and often are put in the areas of the 4 diagnoses on the insurance form, and they'll be covered. But you can't, shoot out in the field because it will be refused. One of the things the DRGs do, which nobody really likes, and oftentimes I think the more empathetic doctors will do, is they'll use more of the diagnoses if they have a severely ill patient. It says that if they're mentally severely ill or if they're physically severely ill, patients are often discharged before they are ready. So So sometimes, and some doctors will find a way to keep patients with using a modifier or an additional diagnosis, or they will send them to hospice if they are at the end of their road, or some other facility for mental health care. Now, there are some ethical considerations of managed care, whether it's any of the three I mentioned. The wealthy may have access to greater care and treatment than poor patients. That sounds pretty awful, but it's true. However, minimum care has to be provided to everyone at every facility. Patients have got to be fully informed of the consequences of obtaining health care. Informed consent is a big deal if they're sent anywhere else. I don't know if you know about the bait and switch, where they're sent from one place to another sometimes because this one doesn't want to take care of the person and that one will. That's not a good policy, and it's really looked down upon, frowned upon. In this case, if this were to happen, the profit is clearly more important than the patient, and nobody likes to hear that. So what types of practice are there? Of course, there's solo. You don't see that too much anymore, where the doctor will practice all by themselves, because they have to do call. There's a sole proprietorship where they will incorporate or have a limited liability corporation. They own it all by themselves. Partnerships, you see a lot. Associate practice, where you see two or more doctors, you see a lot. It's also known as group practice, you see often. And then there's a professional organization like Mayo, where the doctors are there. And now you see it at Essentia Hospital, and you see it at Stanford, where you have doctors that are called hospitalists. And they are not on their own practice. They are paid for, they are employed by and paid for by their individual hospitals. And they work only for the patients, the care of the patients within the hospital, not after they become discharged. So, what about fee splitting? It is absolutely illegal, absolutely unethical. If a physician were to offer to pay for referrals, I don't think I'd want to go to that doctor in the first place. So just know that it hopefully doesn't exist, and know that you can be referred to a doctor and know that they're not being remunerated in any way. There's such a thing as a franchise, where a business is run by an individual, and the person who owns it is allowed to have grant exclusive rights to the market. It's ethical. A franchisee is a person or company that holds the franchise. So that's okay too. Medical specialty boards. There are 23 specialty boards, and their main purpose is to examine the doctors by examination, written examination. They're called candidates up to that point. They are medical doctors, but to be board certified, whether it's the College of Surgeons or the College of Physicians, the main purpose is to improve the quality of medical care so they know more, and encourage the doctors or surgeons or whatever to further their education and training. They are required to do so many hours of continuing education every year. They have to pass apply and pass the exam, and once they do, they are given FACP, or College of American Physicians or College of American Surgeons. Like, as I mentioned here, FACS, the surgeons, FACP, physicians. Having that after their name, you know they've taken an additional test and they are board certified, and that's a plum. You want someone that's caring for you or your loved ones to have that. Now, allied health professionals are both licensed and certified. The licensed professionals are your registered nurse and your LPN, your licensed practical nurse, a nurse practitioner, and a pharmacist. Now, interestingly enough, you go to your certified personnel and you have your physician assistant, which is equal to a nurse practitioner, yet one has to be licensed and one can be certified. The reason is the nurse practitioner has to be licensed because the word nurse is in it, and all nurses are licensed. Physician assistant can be certified, a medical assistant, medical transcriptionist, a lab technician, or a lab technologist are certified personnel, all by examination. The same with the licensees. And last in this chapter is a little something about what is the conscience clause. Now, pretty much every state, but I can't really say this, so I'll say many states or several states have enacted this legislation, and it's saying that anyone that has a moral or a religious objection to helping out with a certain procedure cannot be discriminated against, being that they're laughed at or fired or, looked down upon in that state statute. So if someone is Catholic, for example, and they don't want to be involved with sterilization or abortion, then they certainly want to try not to work in a Planned Parenthood, and they certainly don't want to work for a urologist maybe who can do sterilization. So it has to be thought about. But being that jobs may be difficult to find at any one time, assume you do want to work there. If it's an abortion or sterilization and you don't want to be involved or participate in it, you just say so. You just say so, and you're fine. So I hope that this chapter 4 has helped you, and I look forward to any feedback that you have to offer me. Take care. Have an excellent day.